Hey, everybody. Welcome back to Palm Peeps. I'm joined today by Luke Hedrick, our associate editor who's in charge of rapid fire journal clubs. Hey, Luke, how you doing?
Hey, Dave, I'm good. It's good to be back.
Yeah, I like that shirt. This is you're looking good. This is an episode we're recording video, so you guys may be able to check this out on YouTube or ViewMedi. So you looked apart for today. I love it.
Thanks, man. I got back from the beach like a week and a half ago, so it felt I'm trying to hold on to that vacation feeling.
Yes, you should. It's a good strategy. I'm excited about a new initiative that we're going forward with in Rapid Fire Journal Club. Every time we do Journal Club, I feel like in person at the hospital, people love it. And one very common request that I hear from learners is like, can we do this type of Journal Club review of old landmark trials? I don't have as much of an understanding of those. It's great to hear new trials, but I would like to understand those old trials. And so we're sort of diving in with that mentality as it's July and early in the academic year to try to give a review of some landmark trials that are shaped critical care. And we're being a little bit focused about it. So, Luke, why don't you tell our listeners a little bit more about what we're going to do over the next few weeks?
Yeah, so over the next few weeks, I'm excited. We're going to have a series of episodes about some of the landmark trials in ARDS management. A lot of those are going to be about ventilation, but some of the other non-ventilator aspects of care for these really sick patients. I feel like when I was starting fellowship a year ago and as a resident, I often knew that these were things we did, but I didn't necessarily have the best understanding of the literature kind of underlying those decision making, those management points. And so our hope is that this kind of serves as a deep, quick dive into the deep end for people who are starting training or for people who have ICU rotations coming up.
I like that a lot. Quick dive into the deep end. That's great. Yeah, 100%. And I think that in going through these, we're going to try to do it quickly, but we're going to try to raise some of the issues that really helped define these trials as the paradigm and that also everybody should be considering when they're reading them. All right, great. So we are going to start with, I should say one more thing. I forgot I was going to say this. Yeah, I think also one of the things, I always say this about trials when I'm teaching them is that knowing the names of trials is like being able to do card tricks. It doesn't actually make you a better poker player. It just kind of looks cool every once in a while. So we often do this. We say we do low title because of ARMA, but it's important to understand what the actual conduct was of the trial. So we, one, know, does it apply to our patients? How does it apply to our patients? How did it become so defining? And then two, what are the next steps? Like, what are the remaining questions in research that we have to answer? And so that's what we're going to try to delve into a little bit for this. And so to kick it off, we are going to start with that exact trial. We're going to start with the ARMA trial. Luke, why don't you give us a little background and introduction?
Yeah, so this is the ARMA trial. You may have heard it referred to as the ARDSNet trial as well. This was published in the New England Journal back in 2000, and it was a trial looking at ventilation strategies for patients with ARDS. In terms of kind of the background of where this came from, at the time, some traditional approaches to mechanical ventilation were using large tidal volumes of like 10 to 15 cc's per kilo, primarily in an effort to normalize someone's PaCO2 and their pH at the expense of high inspiratory airway pressures. There was some emerging data at the time that suggested that overdistension and stress induced lung injury could be causing harm, but smaller trials and some uncontrolled studies of lower tidal volumes had varying approaches to airway management and unsurprisingly airway pressure management and had conflicting results, kind of unsurprisingly.
Yeah, and I love to think about this. We take a lot for granted by standing on the shoulders of giants, but when they first were doing mechanic ventilation, obviously well before the 2000s, but there's no normals to sort of go by when we're trying to decide what are the targets and what are the harmful measurements that we may end up getting or the harmful parameters that we should try to avoid. Obviously an evolving landscape that we had to get some more answers about, and there was a lot of preliminary data sort of leading up to this, but nothing definitive. I also will say, I think this is the number one most cited pulmonary critical care trial. I believe I'm right in saying that. So certainly we're starting off with a bang.
Yeah, and if that's not 100% factual, it feels 100% factual. I feel like this is maybe like one of the most cited on rounds papers, if not in the actual literature. So,
Yeah, I believe it's probably even both.
yeah.
Okay, so tell us about what the design looked like and what kind of patients we ended up examining for this study.
Okay, so this was a randomized trial at 10 academic medical centers in the US that ran from early spring 1996 to spring 1999. The primary outcomes they were looking at were mortality and event free days. They defined event free day, it counted if the period of quote unassisted breathing lasted at least 48 consecutive hours. And technically, for mortality, they looked at death before discharge and breathing unassisted, which, for the sake of time, we're just going to call mortality. In terms of their inclusion criteria and who the patients were, it was just intubated patients with ARDS. In terms of their exclusion criteria, essentially the goal here, because there's a handful of these, but big picture, the goal here was to enroll patients early before the ship had sailed with their lung damage and to exclude conditions that may confound their pulmonary mechanics. So they excluded folks who were over 36 hours from eligibility, who had an elevated ICP, neuromuscular disease, severe chronic lung disease, cirrhosis, pregnancy, things that could affect kind of the way your abdomen may impact your pulmonary mechanics. If they had significant obesity, which they defined as like a weight to centimeter height ratio, um, they excluded folks with greater than 30% total body surface area burns, and then folks who'd had a history of a bone marrow or lung transplant.
Yeah, thanks, Luke. The ventilator-free days is a really interesting thing. We won't get into it too much right now, but some of that interesting definition of death before discharge and breathing unassisted comes from the fact that if you just look at vent-free days, then if people pass away early and then are not on the vent, it can skew that statistics. You just always have to be cognizant of it when you're doing the conduct of your trial, which of course they were in this trial. I love the inclusion exclusion criteria for this. Very broad, intubated patients with ARDS, and really just trying to rule out things that would have a disproportionate impact on mortality or your ability to liberate from the ventilator. So within those contexts, who were these patients? At the end of the day, once now we've enrolled, we have these inclusion exclusion. Who are we looking at?
Yeah, so at the end of the day, who they actually got in the trial was middle aged patients that were intubated with early moderate ARDS and multi-system organ failure. So they didn't intend to enroll patients with multi-system organ failure, but the mean non-pulmonary systems that had failed at the time of enrollment was like 1.8 in both groups. So a pretty sick group. And the mean P to F ratio at the time of enrollment was in the 130s in both arms.
Yeah, and as you point out, at least moderate ARDS, but a mean of 130, you have some pretty sick ARDS patients there, right? So that definitely we're examining the group that we want to be looking at. All right, now the most important thing for us to understand when we're going to take the results of a trial and apply it to our bedside practice or future research initiatives. What were the two strategies that they ended up looking at between these patients?
Yeah, so there were 861 patients that got randomized to one of two ventilator strategies. And I emphasize that because I think often this gets remembered as a tidal volume trial, and there was a little more to it than just tidal volumes. So the control arm, they started at a tidal volume of 12 cc's per kilo of predicted body weight with a stepwise titration of those tidal volumes to achieve a plateau pressure of 45 to 50 with a maximum upper limit on the tidal volume of 12 cc's per kilo ideal body weight. And a limitation of this paper is that 10 to 12 cc's per kilo is not necessarily something that we would be doing in any way at this point, but in some ways the reason we wouldn't be doing that is in large part because of this study, and at the time I think this was a little more common than it certainly would be now.
Yeah, I think that's a really important point. It's one of the things that's talked about when you really look at this trial in detail is that at 12 cc's at Pplats of 45 to 50, these are numbers that are nowhere near the standard of care today. And so sometimes in re-examination, people compare 6 cc's versus this sort of extreme high volume and wonder what the comparison would be like at lower tidal volumes. I think, as you said, it's very important to remember that this reflected practice at the time. This is the game changing trial. And I think we've got a lot of data now that suggests that smaller tidal volumes are beneficial for almost everybody in the ARDS group and cohort, with some attention being paid, and that should be paid, to lung recruitability and the personalization of ventilator care. And that's probably the future of where we're going. But even though this is sometimes viewed as a criticism of this trial, that the tidal volumes in the control group were so high, I think it's very reasonable at the time, and I think it ends up giving us a good comparator group.
And so then diving back into the actual intervention or what they did, this will sound more familiar to you guys. This was a tidal volume of 6 cc's per kilo predicted body weight with that stepwise titration to achieve a plateau pressure of 25 to 30. They had a minimum of 4 cc's per kilo, so they weren't going to let you ventilate someone with like 2 cc's per kilo ideal body weight. And if there was really severe dyspnea, you were allowed to increase your tidal volumes up to 8 cc's per kilo ideal body weight, but only if the plateau pressure was still 30 or less. And then anytime we talk about a trial in ARDS, it's important to think about all the other ventilator goals because those can affect your vent weaning and your mortality and whatnot. And so both groups had shared goals of a PaO2 of 55 to 80, a pulse ox of 88 to 95%. Their PEEP was titrated by table. It was the same in both arms. And then they had standardized weaning off the vent by pressure support, and they were required by protocol to do that once the FiO2 was at 40% or less.
Yeah, this just touches on a point that's so hard about ventilator trials, is that there are so many components, right? If you are adjusting just tidal volume, how much PEEP recruitment are you doing? If you're just looking at plateau pressure, how does that involve the optimal PEEP setting? So you really need to have good comparison between the two groups. And as you stated, they were very consistent between the two groups in this. So the differences we see, we really can chalk up to however you want to conceptualize it, tidal volume or plateau pressure. That's great. So we have a good understanding. We have a patient group, moderate to severe ARDS, broadly inclusive. We have 2 ventilator strategies, one reflecting the standard of care at the time, and one with this goal of 6 cc's per kg with a plateau is about 30, right? That's sort of our magic number that we're using here. So what did we find, Luke? What were the outcomes and how did these patients do?
Yeah, so unsurprisingly, since we're talking about it here, this was a floridly positive trial. When you look at mortality, the intervention group had a 31% mortality versus 39.8% in the control group. That's a number needed to treat of like just over 11, which is pretty remarkable when you think about how common ARDS is in the ICU. In terms of vent-free days, the intervention group had about 2 more days free from the ventilator at 28 days than the control group did. And then when they looked at just the percentage of people in the 2 arms that had been liberated from the ventilator by 28 days, that also favored lower tidal volumes, this lung protective ventilation at like just over 65% versus 55%.
Yeah, I mean, extremely compelling evidence and pretty definitive here that we have a benefit both in terms of liberating somebody from the ventilator and then having an overall mortality benefit. So significant differences between the groups and pretty hard to argue with that everything's going in the right direction. What about the safety outcomes? I think we really talk about safety outcomes on the ventilator in an interesting way. And this paper is really a good examination of what we're truly discussing. But things like pneumothoraces, things like barotrauma, what did they look at and what did we end up showing?
Yeah, interestingly, so they looked at barotrauma, and there was no difference between the 2 groups. There was like 10 episodes of barotrauma in the intervention group and 11 in the control group, which is a little surprising. You would imagine if you had plateau pressures that were like almost twice as high, that you would expect there to be more barotrauma. And then in terms of non-pulmonary organ failure free days, which is quite the mouthful, but it's kind of organ failure free days except the lung, basically. That favored the intervention. So it was 15 versus 12, which is interesting. And I think there is maybe some physiological plausibility here too, because remember that like the minority of people with ARDS who die from hypoxemia. It's often the non-pulmonary organ failure that causes mortality in these. And so it's not surprising that if your ARDS patients are doing better, that you would expect their non-pulmonary organs to be doing better too.
Yeah, I think that the safety outcomes are extremely interesting. Hard to explain why there's not a evidence of more barotrauma in the higher tidal volume group, I think we would sort of expect to see that. And maybe with a large enough group or over time, we would see more. But really want to highlight that this incidence of non-pulmonary organ failure reflects something that I think we know now, that patients who are on ventilator settings that are not protective, or really any of the ventilator settings, get ventilator-induced lung injury. And this happens from a variety of factors, and some of this is sort of biotrauma. There's barotrauma, atalic trauma, but this sort of stretch, even if it doesn't lead to pure barotrauma, where you end up having a pneumothorax, can cause increased levels of inflammation, increase adverse effects that then get mitigated or sorry, then get proliferated through the entire system, right? And that's our theory of why using lung protection ends up having a benefit. It's not just for the lungs itself, but for protecting the entire physiologic system. All right. So, in general, if we're looking at this and I'm looking at the outcomes, I think we see lower mortality, more vent free days, and less non pulmonary organ failure in this intervention. So, everything is looking very positive to this. And again, this is why this becomes a sort of landmark trial for us and shapes the way that we manage ARDS going forward. Luke, anything we should know about different groups in this trial or different subsequent analyses, just a sort of more of a deep dive?
Yeah, I think there's, if you look in terms of subgroups at the effect that the low tidal volume ventilation had with folks' compliance, interestingly, they found that that mortality benefit did not vary with static compliance at baseline, which is to say, low tidal volume ventilation, or this lung protective ventilation, is beneficial in ARDS regardless of someone's baseline compliance. But when you look at the actual figure that's in the paper, the trend they displayed would suggest, like in my own interpretation, that there might be a greater benefit in sicker patients, even if it's not enough to reach statistical significance.
Yeah, you raise a really interesting point, and I think the natural next step in that analysis is what ended up happening with driving pressure analysis, is to say who's benefiting from these lower total volumes, who's benefiting for certain PEEP titrations, and why. And I think that you're hitting on that. You can see in the images, you can see in the data, there's this sort of hint that even though it doesn't look like there's an overall subgroup, this is helpful for everyone. Maybe some people are benefiting more. And in my personal opinion, I think where the data supports, although not at a randomized trial level yet, is that what we're going to end up looking at is driving pressure to sort of predict how we should manipulate our vent settings and who may end up having the most benefit. But that's great. I think I think this is what you honed in on, is sort of the birth of the next stage of ARDS management. All right, Luke. Well, this is a great review. What is our one line takeaway of what people should know about the ARMA trial when they're going to take care of patients in the ICU this month?
Yeah, I think the newspaper headline version of this is that a strategy of lung protective ventilation with tidal volumes of 4 to 8 cc's per kilo ideal body weight and plateau pressures of 30 or less improves mortality, liberation from the ventilator, and non-pulmonary organ failure, and that this has become the standard of care.
Couldn't have said it better. I think this is a standard of care for our patients. These numbers of 6 cc's per kg and plateau pressures of 30 are really what we are going to cite in the ICU all the time, and that our learners in the ICU should know about. All right. Well, this is just the first in many episodes coming up about some of these landmark trials. Luke, I'll see you shortly, and we'll go on to the next one.
Yeah, looking forward to it.
All right.